Paul will start the recording and then I will share my screen. So thank you everybody for being here. It's March, it's getting to be that springtime. And so we are here for the March version of the JVS Online Journal Club. We have two exceptional articles that we'll be discussing this evening. And our two host institutions are the University of Buffalo and UTMB, which is the medical branch in Galveston. Dr. Linda Harris, who professor of surgery, and her twice I put on there. So, that's exciting. And also Dr. Rose Gooding, who is her vascular fellow from the University of Buffalo, making a repeat appearance here for us and hosting again, which we're very grateful for your support. And then Dr. Mitchell Cox, who is the chief at the Division of Vascular and Endovascular Surgery at UTMB, and his third-year integrated resident also helping us out tonight. This is their first time, so it's exciting to have new groups come and participate. Dr. Darren Schneider is our author guest. Our second paper is the authors are from out of the country, and so they will not be able to attend, but he will be here to talk about and answer field questions from the audience, which is always exciting to have the audience, or sorry, the authors here. And then we have our two guest moderators. So Dr. Nagasheeth, who is the Associate Professor of Surgery, Associate Program Director also, and Program Director for the Vascular Surgery and Integrated Residency Program. And then, of course, Dr. Joseph Hart, also Associate Professor of Surgery from Medical College of Wisconsin. So just a couple of little housekeeping things. Please stay muted. Add your comments and questions to the chat because the moderator may call on you to speak if there's something that's a little confusing. Of course, we record all of these for on-demand access. And then the April JVS Online Journal Club will be Wednesday, April 10th, 6 p.m. Central Time. That'll be hosted by the Carolinas Medical Center and also the Jobst Vascular Institute. Again, all of the dates for 2024 are posted. Those are at vascular.org. The specific web page is here, but when you go to vascular.org, you can just search in the search bar for JVS Online Journal Club, and that'll pop up. You can register now for all of the upcoming sessions, so you can get a calendar invite and a link, and then we will hopefully see you in April. So with that, I will stop sharing my screen, and then we can turn it over to our first lead author, Dr. Cox. I believe that's you.
All right. Okay, I'm going to go ahead and share my screen here. Okay. All right. Can everyone see my screen here?
Absolutely.
All right, great. Thank you so much for everyone for coming to the Journal Club. The article we'll be discussing is from the March issue of the Journal of Vascular Surgery, and it's from Drs. Wang, Xu, Luo, and Wu from Changsha, China. Today's article addresses the topic of calf DVT, or rather isolated calf DVT, which is a variety of DVT that we still don't know exactly what to do with. As we all know, all DVTs are not necessarily the same. For instance, iliofemoral DVTs have a much higher risk of post-phlebitic syndrome, and we often get more aggressive about thrombectomies with those patients. And calf DVT refers to thrombus in the veins distal to the popliteal vein, so to the tibial veins. For those of you in institutions which don't talk a lot about calf DVT much, or maybe don't even look for these DVTs on your duplex scan, this is what we're talking about. You have the axial veins, which we think about often, the anterior tibial, posterior tibial, and perineal veins, and the muscular veins. These are the veins within the gastrocnemius and soleus muscles. Now, in the past, duplex technology and duplex protocols may not have been sophisticated enough to consistently image these tibial veins, so no one thought much about them. But as the technology improved and we started looking for calf DVT, we started to find them. And the question became what to do about it. Is this just another DVT with a significant risk of PE, or is it really more something like superficial thrombophlebitis, which is not a significant PE risk? Do you anticoagulate these patients or not? And it's not a trivial question because systemic anticoagulation has real risks of major bleeding events. And we need to know about this because about half the DVTs today that we see in 2024 are actually calf vein DVTs. And the studies are a little bit conflicting. Some of the initial literature suggested that there was a very high risk of PE, but some of the more recent data suggest that really the risks of PE are relatively low. So which is it? Well, there are a lot of guidelines out there, and these guidelines are honestly a little bit unclear about what we should be doing with calf DVT. The simple fact is that good guidelines require good data, and the data may not be there when it comes to calf DVT. The chest guidelines came out in 2021 and suggested that serial imaging rather than automatic anticoagulation is the standard. But frankly, I'm not sure most people are following this in our area. You know, a DVT is a DVT, and people get anticoagulated if we put tibial vein DVT on that report. So our authors are stepping into this controversy with this meta-analysis, and they're going to look at calf DVT specifically and really whether all calf DVTs are the same, whether we should be treating axial vein DVTs the same as a muscular vein DVT, and do we really need to anticoagulate these? And so I'm going to give the presentation over to Dr. Suka Ghoshi, and he's going to present the data from the paper.
Thank you, Dr. Cox. I'm going to share my screen. Can everyone see the slides? All right. So thank you, Dr. Cox. I think they reported some probably not conclusive, but pretty interesting results here. The objective was to pretty simply compare the outcomes between the axial vein DVT versus muscular DVT to see if the outcomes are different and if treatment recommendations need to be changed to reflect this difference. The authors conducted a meta-analysis of the existing literature on calf DVT and extracted these data points. These were the outcomes of interest. It is of note that the primary outcome was a composite outcome of recurrent calf DVT, including new contralateral calf DVT, increased thrombus burden within the same named vessel, proximal propagation, and PE. There was also a number of secondary outcomes. Authors did an extensive literature query and ended up with 195 full-text articles that were fully assessed. 13 of these were of such quality that they could be included in the meta-analysis, and all were published between 2009 and 2022, so relatively recent. Notably, all the studies used compression duplex as a primary diagnostic modality rather than earlier methods such as venography. And this yielded a total of 4,889 patients. Here is the Prisma flow diagram for their research strategy, which, as you can see, started off with over 11,000 records and culled this down to 13 studies. Here they included 13 studies. And as Dr. Cox said, the believability of meta-analysis really depends on the quality of the underlying studies. Notice here that a variety of countries and regions are represented. 2 US studies, 5 European, 1 each from China, Korea, Singapore, Australia, and Brazil. There's one randomized trial from Italy, but the rest are cohort studies, either prospective or retrospective. And although there are not a lot of randomized studies here, the numbers are pretty good with several hundred patients in each. And as I mentioned, all these studies use compression duplex for the diagnosis, which is probably the modern standard at this point. So the definition of axial and muscular DVT, percentage of thrombophilia, anticoagulation regimen, and the follow-up period varied widely, as it does in meta-analyses often. So the primary endpoint was recurrent venous thromboembolism, and there were 12 of the 13 studies that reported on this outcome, differentiating axial and muscular DVT. These studies involved 4,717 patients. VTE rates were also compared in patients that were anticoagulated versus those that were not. So this is really the bottom line. And there was, in fact, a higher VTE recurrence in a group with axial DVT. Axial DVT is more risky as far as recurrence. But interestingly, anticoagulation did not change the recurrence rate. And the larger recurrence rate was only demonstrated in studies with longer follow-up. So the risk of recurrence seems to be a late risk. And also, the difference was insignificant for symptomatic patients and prospectively designed studies. So that's a point to be careful about. As you can see, the difference in VTE recurrence between the axial and muscular DVT was really not that big, with the lower end of the 95% confidence interval right at 1. This study also had a lot of secondary endpoints that were quite interesting, although perhaps the results are not as convincing given that these endpoints were not addressed by most of the studies reviewed. Axial DVTs resolve more often than muscular DVTs, which is interesting, but perhaps not very clinically relevant. Do we care if a soleal DVT does not resolve? Perhaps not so much. As one might guess, axial DVTs are more likely to propagate. And the more interesting secondary endpoint, perhaps what we may want to have as a primary endpoint, was their PE rate, axial versus muscular. And it turns out that axial DVT has a higher PE rate, which is exactly one might intuitively suspect. But there were 0 deaths from PE, 0 deaths out of 110 PEs in 2,222 patients. So in conclusion, this study reports that muscular DVT does actually have different behavior compared to axial DVT. But anticoagulation does not seem to have a large clinical benefit, and the overall fatal PE rate is quite low. So is this study actually helpful? Well, in some ways, it might make things more confusing. It certainly does appear that muscular DVT is different than axial DVT, but what are we to do about that? The paper has some results that are somewhat divergent. For instance, we see a significant PE rate related to calf DVT as a whole, but on the other hand, we see no benefit from anticoagulation. So how are we supposed to treat these people? It's going to be hard to make any firm recommendations based on this current evidence, but this paper does raise some questions for further study. We'd certainly like to see some large dataset analysis to find out if anticoagulation is of any benefit in these patients, and if so, which patients benefit the most. Thank you to Dr. Damouzzi and Dr. Humphreys for inviting us to present today, and thank you to all the attendees for listening. We look forward to hearing everyone's comments.
Dr. Sukugoshi, that was great. Thank you very much for a comprehensive review of that article. It's a very interesting idea looking at calf vein and muscular vein DVTs and separating them out. Did you find anything different in terms of symptomatology for the patients? Were these incidentally identified calf vein DVTs and muscular DVTs? Were they symptomatic? Was it stratified by the authors?
The included studies actually varied, had like various indications for the studies. So some had only included symptomatic patients versus some just included every incidental finding as well. They did conduct a separate analysis just to see if there was any difference in only the symptomatic patients, which they didn't find any difference. So that was quite interesting.
Yeah, it was my reading of this. It was a fairly heterogeneous population because of all the different studies having different protocols. There are some questions in the chat. The first one I think is an interesting question. DVT in the lower leg needs rest for some time, or early mobilization is better? That's a question. I'll open it up to any of the faculty, and then I have my own thoughts on that.
Why don't you kick us off, and then I think we'll have a couple of other
Sure.
faculty kind of comment.
Sure. So actually, last year there was a systematic review published out of the Netherlands looking at a very similar topic. Wasn't just isolated to tibial vein or muscular veins. It looked at all lower extremity DVT. And what they found was early mobilization with acute DVT in the acute phase had lower or better quality of life on validated surveys, lower rate of PTS long-term, post-thrombotic syndrome, and overall the patients did better with very low risk of any untoward events like pulmonary embolism or progression of the DVT. So the authors found that it looked at, I think, 75 articles they looked through for the systematic review. It was very well done, but they identified that early mobilization for DVT actually had better long-term outcomes for quality of life, which I thought was cool. It's actually in a Dutch dermatology journal, of all things. So if anyone else has any comments on that, great. If not, we can go to the next question on it. It seems like there's a bunch of questions now.
I think what was interesting about what you just said is the recommendations from, of course, from the chest guidelines, and then sort of this idea of walking. We have a lot of somebody else mentioned, I think, Mitch, you said that, a DVT is a DVT in a lot of places. And somebody gets diagnosed with a DVT at our institution, and not even a physician sometimes is who puts them on anticoagulation. There's a pharmacist that they just kind of get sent to. We've actually had to start putting in some of the recommendations from the guidelines and putting together guidelines so that not everybody just gets started on anticoagulation for a muscular vein thrombosis, for a calf vein, and we recommend that they walk and have some other things. I'd be interested if anybody else has done anything like that.
Missy, it's Anthony Figali. We've done the same at Syracuse too, at SUNY Upstate. We've basically, in the soleal clots, we treat them conservatively. We usually put them, and what I mean by that is we put them on antiplatelet, let them walk early, and then we just do an interval repeat image. And if there's no evidence of any propagation into the popliteal deeper system higher up, we just let it be. And then they'll usually get an interval image in a couple of weeks. So we've done the same thing with us because we feel that over anticoagulating has been an issue too.
So there's a question from Dr. Hingarani. How about the patient with multiple calf vein thromboses? Some prior data suggests that patients with multiple calf vein DVT had almost the same rates of PE as FEMPOP DVT for inpatients.
Mitch, what are your thoughts on that?
I'm sorry. What was the question again? I missed that.
It was about multiple calf vein DVTs, and that there's prior data that suggests that patients with multiple calf vein DVTs have about the same risk of pulmonary embolism as FEMPOP DVTs for inpatients.
You mean patients who have had multiple separate episodes of calf vein DVT? We're talking about, I'm assuming.
I would think so.
Yeah. So that would make sense to me. I mean, if you've had it seems like that would be sort of a risk factor for someone who's at perhaps hypercoagulable or at risk for further DVT. So maybe it's not so much that the PE is coming from the calf veins, but that's a patient who's hypercoagulable.
That just thinking about that in terms of the multiple calf vein DVTs or even multiple deep venous thrombosis, there are certain practitioners in our hematology and oncology group that once they've had multiple episodes, even if it's fairly limited, will leave those patients on lifelong anticoagulation just because there's some data that shows that if you do have residual chronic thrombus, you're more likely to develop recurrent deep venous thrombosis. And it's fascinating that even if they don't have they have a negative hypercoagulable workup, they'll still be left on anticoagulation just because of that residual chronic thrombus that's seen on ultrasound. I don't know if people are seeing that at their institutions as well.
I think that data is pretty weak about venous duplex findings. I suspect it's more to do that if they have a VTE event and then have another VTE event and have a third VTE event, you kind of have to conclude that they are prone because it's all based on their future VTE risk.
What do people do for this is an interesting comment also, for people that have had orthopedic procedure and that then they find a isolated calf vein DVT after a lower extremity orthopedic procedure? What's the standard practice? I can tell you, we just rescan at University of Maryland. Unless they're traumatically symptomatic or something like that, we'll rescan them at 2 weeks to check for propagation.
I was just thinking that it kind of does, in that case, it might depend on how ambulatory the patient is, right? I mean, if they're still limited ambulation, they might be at higher risk. That might be someone we would consider anticoagulating.
I'd have a little bit of a question about the orthopedic procedures at various institutions. Our providers do send quite a few of those patients home on prophylaxis for a couple of weeks. And so that's always something we don't really have as much now that the providers are sending them home for a few weeks of prophylaxis. And I think that's become fairly standard at multiple places, but I could be wrong.
Yeah, the orthopedic literature actually supports that, sending them out with Lovenox.
Ruth, did you want to contribute?
Sure, thank you. I appreciate Mitch and the team presenting this and the opportunity. So, I had to look at this past year when I had a patient, and actually you all are very familiar with the CHEST guidelines, and they come out with updates all the time. And there was an update in the CHEST guidelines in 2021, which, if you dig down into it, recommendation number 18 talks about patients who need to be anticoagulated with a calf vein DVT who you think are at risk for progression from superficial to deep. So that's where the anticoagulation comes in. And the recommendation talks about those who have extensive deep venous thrombosis as you described a calf vein thrombosis. Those that are really symptomatic, those that have a previous history, cancer or recent surgery. So I would think that your orthopedic patients might come in there. There's also a systematic review that was done by Nikos Lapropoulos out of Stony Brook, looking at the severity of pulmonary embolism after calf vein DVT. And looking at the literature, it was all over the place, but the highest was 6.2, but none were fatal. The conclusions were fairly bland, just saying that a PE is infrequent and clinical severity is unknown, which doesn't tell you anything. I think and we published a couple of papers in JVS VL on this, and I think, my position is that looking at the literature, and there's not much, so again, all of those out there who are looking at this, I invite you to think about some future study. This may be a group of patients who we're getting lucky with. It may be patients that need to be followed up. And somebody mentioned the serial CT or the serial duplex scans. But you also have to weigh that, if the patient can't come in for a duplex scan, they live, 400 miles away in Texas or wherever, that you may have to weigh that risk-benefit ratio towards anticoagulating them for a period of time. Thanks for the opportunity to comment.
Thank you. Well, there's a lot of conversation here about so many different things that people are doing. I think it's hard. I think this is a really tricky area. Linda, or Dr. Harris, do you want to take us to this concept that Dr. Schneider's talking about, percutaneous axillary access? We're going to chat a little bit about this.
Just trying to get to my correct, 1 second. There we go. Can everyone see my screen?
We can.
Okay, beautiful. So I'm going to talk a little bit about percutaneous axillary artery access for complex endovascular procedures. Again, it was an article in the recent JVS. So the authors did have some prior experience, and the axillary conduit they reported on in the past also, where they started doing that for people who needed large sheaths when they were doing these complex aortic procedures. And they had no intraoperative complications, but they had about a 6.9% postoperative complication rate, and that included ipsilateral hand weakness and a minor stroke. So that was a study in 2017. Then I think most likely guided by the fact that in the cardiology groups, they're being more aggressive with using percutaneous axillary, they decided to trial their hand at that and did publish in 2019 about percutaneous axillary artery access. They had 46 patients and they had what they considered 89% technical success. They did have 5 patients who needed covered stents, and 4% patients had ipsilateral paresthesias. So you'll hear a little bit later from Rose that this is, or Dr. Gooding, this is a follow-up to that previous study. So first of all, percutaneous axillary access is not a new development. Actually, it's kind of interesting when you look at the literature. 1996, there was hepatic artery infusion for a tumor, and it was transaxillary by IR. 2012, the cardiology group started using it more for TAVI for high-risk patients. And there was a study there where they had successful closure, 71 to 100%. They used ProGlide and they also used ProStar. They used stent grafts for failures, and they had no surgical conversions. So again, why would we consider percutaneous axillary access? Now, most of us know that we do a lot of percutaneous femoral access, and there are a lot of reasons for that, which decreasing the wound complications, getting the patients out of the hospital sooner. This has really been more popular in the cardiac literature, and a lot of it's because not all of these are done in the operating room. They actually have used it for mechanical circulatory support, and that's where it really came up when, if they did it percutaneously, they didn't have to have general anesthesia for these patients who are already in pretty severe situations from their heart. They've basically found also that 13 to 20% of the patients had limited femoral access when they were trying to do things like TAVRs, so they would try the percutaneous there. Again, they found that it avoided incisions, avoided conduits, and potentially avoided general anesthesia for some of those people. From their literature, their contraindications are prior vascular procedures or surgical repair in the axillary artery, a prior stent graft. Relative contraindications were things like calcification, stenosis and tortuosity, aneurysmal dilatation, and prior dissection. Anticoagulation was relative as well because of increased risk of bleeding. If the patient had an ipsilateral fistula or an IMA bypass graft, that was also a relative contraindication. They recommended thinking of going to the contralateral side. And again, pacemakers and defibrillators would be a relative contraindication. The biggest risk that they've noted in the cardiac literature is hematomas with neurologic compromise, compression of the plexus. So what about in our own vascular surgery background data? Retrospective study done by Albany in 2015, they were using 6 and 7 French sheaths. They did perclose 36% of the time and angioseal 64% of the time. They had 2 deaths and 1 return to the operating room for a hematoma. Earlier literature basically showed about a 3.3% complication rate. Concerns, again, were plexus injury, pseudoaneurysms, distal embolization, or thrombosis. They recommended always getting a CTA prior to considering this to assess patency and calcification in the vessel, always starting with a micropuncture. And one of the benefits of using this technology, percutaneous, is you can keep the arm tucked. As most of us know, when we're doing these complex aortic procedures, the II is often coming in from the side. If the arm is out, that complicates our ability to angle the II to image what we need to see. So there is an axillary access registry to monitor safety. And there was a study from this where they looked at 105 patients. Again, these tend to be cardiac, and these were patients who had indwelling devices for multiple days. Now, the median the device was in was 2 days. So it's not like our procedures where we're putting it in and taking it out immediately. They found 61% were closed with a closure device, 17% used a closure device plus a stent graft, 15% had balloon tamponade plus either a closure device or manual compression, and 5% had open repair. They did have 15.7% procedural complications. 1% were minor bleeds or hematomas. About 6% were transfusions. Hematomas more than 4 centimeters was 2.9%. 2.9% did have a neural complaint or a plexus potential injury. 1% hand ischemia and 1% pseudoaneurysm. So as you can see, the risks don't seem like they're massively large. And actually, when you look at the open axillary interventions, we can still have strokes and issues like that because we're crossing the arch and crossing cerebral vessels too, potentially. So the question is whether or not this is better. And I will turn this over to Dr. Gooding at this point to go through the actual study.
Thank you, Dr. Harris. So the goal of this study was to further evaluate the safety and learning curve of percutaneous axillary artery access in FBVAR and to describe the best practices for obtaining safe percutaneous axillary access and managing potential complications. This was a retrospective review, single site, single insertion, with the primary outcome being failure of percutaneous closure requiring intervention, and secondary being hematoma, paresthesia, weakness, stroke, and then evaluating the learning curve. So the methods was the access technique. The axillary artery was evaluated pre-op on a CTA. It was noted to be non-aneurysmal, free of significant disease. This was performed under general anesthesia in a hybrid suite. The upper arm was prepped sternum to forearm, and the arm was abducted to 90 degrees. Ultrasound access was then performed at a shallow 30-degree angle. This was exchanged for a microsheath for 5 French over a stiff glide wire, and IV heparin was given. 2 perclosed proglides or pro-style were deployed in opposite directions, 90 degrees apart, and a short 8 French sheath was placed, establishing through wire access from ax to fem. The large bore sheath was placed over the through wire, and the arm was then adducted to the patient's side. For closure, the arm was replaced into the 90-degree abduction. A 90-centimeter long 7 or 8 French sheath from the femoral over the through wire was intercepted into the axillary sheath until it's in the distal subclavian. The through wire was removed. A stiff glide was advanced from the axillary sheath to the abdominal aorta. The axillary sheath was retracted. Wire access was obtained, femoral to brachial, and the axillary sheath was removed, and the perclosed sutures were tightened. Angio was then performed by the femoral sheath, and if this was satisfactory, the wire was removed, perclos were tightened and locked, and then completion angiography. This was plus or minus using a Rommel tourniquet, and then protamine was given at the end. For the statistical analysis, there were summary statistics, mean with standard deviations, median with interquartile ranges, skewness and kurtosis were used to check for normality, and the analysis was via stata 12. For the results, there were 146 patients with attempted access. However, 1 was aborted due to the wire being lost. Mean age of 74, 87 were male. Crawford 1 through 4 as listed. For the left axillary approach, there were 115 access. On the right, it was 30. The sheath ranges in size from 8 to 14 French with numbers listed. And the perclose failure was noted to be 10 at 6.9%. A Viabon stent graft was placed in all 10 patients, 8 of them via femoral access and 2 of them via ipsilateral brachial. And this was performed with proximal balloon occlusion from the femoral, and there were no conversions to open. The TIA was found in 2 patients, 1.3% resolving at 1 month. Transient paresthesias in 2 patients, 1.3% resolving at 1 month. Perioperative stroke at 3 patients, 2.2%. Clinical symptoms and CT confirmation. 1 of these was unrelated, a hemorrhagic stroke, and 2 were possibly access-related with embolic strokes. There were no access site thrombosis, hematoma requiring transfusion, or access site infections. and a follow-up CTA showed 100% axillary artery patency. There were no statistical differences between the patients who required covered stent placement and those who did not. However, there was a trend towards decreased incidence closure failure over time, with 7 out of 73 being 10% within the early cohort and 3 out of 72 being 4% in the late cohort, though this was noted to be not statistically significant. However, you can see the curve here. So technical features, what they wanted to find was a standardized approach to be followed. So as was stated earlier, the patient was positioned and prepared in a specific fashion. They're using an articulating arm board. Access and closure were both performed at 90 degrees abduction. The prep was from midline of chest to forearm in case there was need for additional access. The axillary artery anatomy was important, noting that the second aspect of the axillary artery posterior to the pec minor was chosen, given its 2 branches, being posterior to the pec minor, compressible against the rib, and there were no nerves anterior. Access was performed under ultrasound guidance in every case. There was always a downward compression of the probe to ensure no brachial plexus or other structures between the artery and the pec minor. Access with compression with a 21 gauge needle, shallow needle angle of 30 degrees, and a short stiff glide wire during sheath and perclose introduction. For axillary artery perclose technique, there is a different tactile feedback that they noted from femoral use. You need to ensure and confirm blood return from the marker lumen before deploying and engaging the foot plate. Perform this under fluoroscopy to ensure that the device is tracking well in the artery. Perform gentle traction on the rail suture while advancing suture trimmer or knot pusher, and do not have any jerky movements. These arteries are more fragile than the femoral. And you can use a Rommel tourniquet over the sutures for tension. For large bore sheath introduction, introduce over the AxFem through wire. And you can clamp the wire at the femoral sheath at the hub of large bore axillary sheath dilator, so the wire can be used to pull the large bore axillary sheath into the descending thoracic aorta as it is simultaneously advanced from the axillary artery access. For exit technique, using the 90 centimeter 7 or 8 French sheath advanced from the femoral to the subclavian over the through wire. Large bore axillary sheath is then removed after the guide wire is placed. Axillary sheath to the aorta or femoral sheath to brachial. Femoral sheath for the angio is confirmed the hemostatic closure and deliver the occlusion balloon or covered stent if access failure. If you're unable to advance the femoral sheaths to the subclavian, access can be maintained and angiogram can be performed by exchanging the large bore axillary sheath for a 5 French micro. The perclose are tightened and angio is performed through the micro. In failure in this event, the guide wire can be replaced and the large bore sheath reintroduced while additional access is obtained to deliver a covered stent or surgical cut down is performed. And here is a diagram of this procedure of exit technique. You can see the sheath going all the way up and over on the right side. And then you can see on the left within these A, B, C, and D, a failure of a closure, placement of a stent, and then the angiogram of completion, as well as a CT showing a patent stent. The study limitations, this was retrospective, non-randomized, and a single advanced operator, and the Perclose, ProGlide, and ProStyle off-label use. In conclusion, percutaneous axillary artery access is safe and effective for delivery of large bore sheaths during complex EVAR or TAAA. Successful primary occlusion in greater than 90% of patients. But there is a suggested learning curve, and they recommend the application of best practices to ensure safety. Thank you.
Can you hear me, Dr. Demizio?
We can.
Okay, great. We had one question. Thanks very much for those presentations, Dr. Gooding and Dr. Harris. We had one question from already from Dr. Humphreys, and that was, did we see any impact with side of axillary access on associated neurologic events? And that was a question either for Dr. Schneider or for the Dr. Gooding or Dr. Harris.
Yeah, I can speak to that. Not all the events were attributable to the access. There was that one intracranial hemorrhage related stroke, and then otherwise, I think the numbers are too small to determine. We had 3 total. One was an intracranial hemorrhage, and then there were two strokes. And I know that at least one was ipsilateral, but I can't recall exactly. It's consistent though with or even lower than a lot of the reported incidents of stroke when upper extremity access is used for complex EVAR procedures. So it's an inherent risk to coming from above.
I was going to say also from the cardiac literature, while it occurs, if you think about our rates when we're accessing the axillary, brachial, radial, anytime you're crossing that region, we have that risk. And so I don't know that it's any higher than the risk anytime we access the upper extremity. If we can do it all from the femoral, that's great. But the good thing is this doesn't seem to be higher.
Thanks for that. Dr. Hingorani asked, to what do we likely attribute this learning curve?
Well, I'm hoping that anybody who reads the paper and tries to reproduce this will not have quite the same learning curve. That was one of the goals of writing the paper and spending some time in the discussion to give kind of our best practices and learning over time, because hopefully others can benefit from our learning curve and have a shorter one. That's my hope. But it's a different procedure, and the artery is deeper. It could be a little bit more mobile. You gotta get used to imaging it. The tactile feel, as was mentioned by Rose, can be a little bit different. So it's just a slightly different beast. So I think that explains the learning curve.
I think some of the points too, if you look at the literature where cardiology is talking about it as well, the angle is very different. The 30 degrees is really important. Most of the time when we're talking with our trainees, they're going at a much steeper angle. And again, the friability of the vessel, so being gentle with the ProGlide instead of being a little rougher like sometimes people are. And there was also a question in the chat about arm in versus out. Most of them do recommend arm out to get the access, but once you get it, then you tuck the arm. And it's just to, I think, stabilize the vessel and for the angle and to make it better while you're doing it, but it doesn't need to stay out after that initial point, and there's nothing in the arm.
Agreed. And I think arm out is way better. I've done it both ways, but it straightens the artery, and because the artery, if the arms are at the side, can be somewhat relaxed and redundant, can have a tendency to kind of roll away from you. The other thing that's beneficial, and I do this for femoral access as well, even in obese patients when we're doing it percutaneously, is I don't hesitate to step on fluoro and make sure that the device looks like it's tracking smoothly into the vessel, because particularly in a larger patient, the axillary artery can be fairly deep, and that's why we use the stiff glide wire, shallow angle, arm extended and abducted when we do this. And then if we need to, step on fluoro and make sure that the device is tracking as you would expect it into the vessel.
Dr. Schneider, to clarify that, so are you saying in general now still, even though you're far out on your learning curve, you'll leave the arm out, or do you just start with the arm out and then tuck and take advantage of that later?
Well, I always start with the arm out. I like to access it and do the pre-close technique with the arm out. Also, when I close, I put the arm back out. But we have an articulating arm board that we use, so we can rotate the arm back in and tuck it at the patient's side once the access has been obtained. But I think for both gaining the access and doing the pre-close, and for your exit and taking the sheath out, I think the arm should be out abducted. It's much easier to control the vessel, to compress, to keep everything straight.
Great. Dr. Gooding or Dr. Harris, did you have anything else to add to that?
I just have a question for Darren as to, do you think we should be using the axillary artery more when we're doing other procedures from the upper extremity where they're not the complex aortic, instead of using the brachial if the radial is not suitable? Because the brachial has a lot of complications. If you get a hematoma there, it can be devastating. No good closure devices. The vessel is smaller, much more spasm. Would you go more to the axillary instead of the brachial and do it a little cut down?
Well, I mean, the reason we use axillary is when we're doing larger bore access, and that's because it's a larger vessel, so we're not necessarily going to be occlusive. Sometimes if you go more peripherally with brachial access and you're putting in a 12 or 14 French sheath, you've got an ischemic arm the entire time you're working. Whereas in the larger axillary artery, you usually flow around your sheath and you don't have an ischemic arm. So we use the axillary access more specifically for large bore. And the other benefit is that we can tuck the arm in, and the other thing is that we can shorten our working distance as well by using the axillary artery. I don't like brachial access because in our hands and in the literature, it's associated with a much higher complication rate when you try to do it percutaneously. So my general rule is anytime I go larger than 7 French with brachial access, and I don't use closure devices for that, I do a cut down to control that. So I prefer radial or axillary, and it really depends on the profile.
I guess what I'm asking is if you're doing a 6 or 7, say you were going to do an iliac or SFA intervention on a patient where you couldn't go up and over, maybe they've had an EVAR before, or there's some other reason you couldn't do that, would you, and the radial was out, would you go brachial, or would you now, with your experience, choose to go axillary? Just as a question.
I mean, again, if working length wasn't an issue and I'm 6 or 7 French, I'd probably still go brachial. But if I need, if the devices aren't long enough, you've got a tall patient, certainly, the axillary approach is great. So I've used it for other things besides complex EVAR, I think is what you're getting. And, I think that each case gets individualized, and we decide, what working length, what devices we're using, what profile, what the patient's anatomy is, and they're all options that you can use. So, but you're exactly right, and you don't necessarily have to do 2 per closes and things if you're doing just 6 or 7 French access.
Dr. Cox had a question for Dr. Schneider and our reviewers as well. He was wondering about whether percutaneous access impacts recovery in any way you've been able to measure so far compared to a cut down.
There's a lot of confounders. So we have definitely shown when we look at different, process measures for our, because all this was done in the context of my physician-sponsored IDE. So the data is actually pretty good because we prospectively capture all the data on this. When we've transitioned and went entirely over time to a fully percutaneous approach for complex EVAR, there has been a significant reduction in blood loss and a significant reduction in operative times. Now, there are a lot of potential confounders as well that we've also gotten better over time. And so is it just learning curve, or is it that we've gone percutaneous? But in my opinion, there's no question that it reduces blood loss. And I do think it's easier for patients to recover, because even though you can recover from a little groin cut down or an axillary cut down, it's still a surgical incision that you're healing up from, and there can be, complications and morbidity and pain associated with those. So I do think that it's better for patients. I think that it makes us faster, and I think it reduces blood loss. And so I think it's a preferred.
I'm going to edit one of my earlier questions because I think we've kind of answered it, but and this would be for the group of 3, but again, maybe primarily Dr. Schneider. What pleasant or unpleasant surprises if I adopt this where I haven't done it before and I've done 50 and I'm getting out on my learning curve? Are there any surprise benefits that are not obvious here, or any other costs or disadvantages to that you could amplify beyond what's been discussed so far? So risk benefits or advantages, disadvantages of adopting this or using it more that have not already been discussed.
My hope, and that's also the purpose of publishing and sharing this experience, is number one, to tell people hopefully how to do it safely, and so that they can not have exactly the same learning curve that I had. But also, I do think it should be more widely adopted and used. I think that there are downsides to everybody says, it's not a big deal. You can do an axillary cut down and patients tolerate it and it's fine. But you have an incision, the patient's anticoagulated during the procedure. There is ongoing oozing through the open incision, so the blood loss is increased. There are still the same risks of brachial plexus injury when you do an open exposure of the axillary artery. And if you're sewing on a conduit and leaving a little cuff of Dacron, we've all been called, you know, whether it's for us or the cardiac surgeons, that those can get infected too. And so I think that the open procedure we can all do, but it's not risk-free. When I look at, you know, kind of what I've learned over time, risk benefit, weighing the pros and cons, unless there's a contraindication, I'm going to do it percutaneously. Now, there may be some caveats also with profile of the devices that you're introducing. I mean, our comfort zone is really in 12 French, more or less. The vast majority of the sheaths that we use were 12 French dry seals, but I have used up to 16 French percutaneous.
Awesome, thanks. Dr. Figali, I forget, guys, what time we've got to stop. Can I throw one more question in here from Dr. Figali, or are we up against it?
No, I think we should definitely do this one last question, because I'd like to hear what Dr. Schneider has to say about this, actually. So
great. Dr. Figali, Dr. Figali asks about, and I'm not familiar with this device myself. We may, in fairness to everybody, ask Dr. Figali to mention, just briefly outline it, but I'll throw the question out first for the reviewers and for Dr. Schneider. But he asks whether the MANTA might have a better role in the axillary, given less foot plate and length, and they're beginning their experience with it. I guess I'm reading between the lines. They have some enthusiasm.
Yeah, and maybe Dr. Figali wants to comment, but I'm familiar with the MANTA device, but I don't have a significant experience with it. The MANTA device is a device that can do large pore closure without having to do pre-close ahead of time. So if you had a large sheath, say you were doing a ruptured aneurysm and didn't have time to do pre-close, just put the sheath in, you could still use a MANTA device in the femoral access for percutaneous closure and not necessarily have to cut down. In my mind, the downsides with the MANTA is it's harder to maintain wire access. There's a very large collagen wad that's used on the outside to tamponade and to create the closure. You're not able to re-access that site for, I think, 3 months afterwards, because it takes that much time for that wad of stuff to soften up or go away. And there is a foot plate. And so, you know, with pre-close, we're not leaving a foot plate in the artery. And so, you know, I'd have some concerns about MANTA, but I have no personal experience using it in the axillary artery. For us, the pre-close works well, and it's the same surgical principles we're used to of putting a suture in the artery. And so that's what I've been doing.
Yeah,
but there could be a role if you need to close afterwards, if say your per-close doesn't work, or if you weren't able to pre-close.
Yeah, I agree with Dr. Schneider. I mean, it's a new technology. We started using it a couple weeks ago. The value, like you said, it's for post-closure. And again, there is a foot plate. It's using that biodesorbable scaffolding. We're going to start to see in the tibial stent data that's starting to come out now, same sort of material. But it is a smaller distance of a tip than a ProGlide. You know, my challenge in the ProGlides I've had is when they're very tortuous iliacs, you really have to watch that thing take those turns and have that foot plate catch and the needle fire. This kind of avoids that if there's a lot of depth or deepness or tortuosity with that vessel. So just a consideration as this technology evolves too. But it's about a month or 2 months for it to dissolve that external collagen plug. Do I think it's the perfect closure? I don't think anything is perfect yet. We're far away from that, but it's just a consideration maybe in the axillary at one point.
Yeah, it's significantly more expensive than per-close.
It is. It's about $400 or $500 more. That's correct.
Dr. Schneider or anyone here, do we know if anyone's looking at this in the Aortic Research Consortium in a larger data set, even than this?
I don't know. I mean, I'm part of our. I think that I have to say that I'm in the minority, and that most of them are not doing percutaneous access. The reality is that we've all cut down on our upper extremity access, and we're doing almost everything from the groin now. We're using steerable sheath technology. that being said, I think we should be selective, and there are clearly cases with diseased tortuous aortas or iliacs, and for other reasons that if you're doing staged or sequential deployment techniques, that femoral access is not good. So there still is a role for upper extremity access. But whereas we used to do it in 100% of cases for branched EVAR cases, I'd say that it's now about 20% of cases at most. So the experience is shrinking with upper extremity access. And I can't say that all of my ART colleagues have enthusiastically joined me. I don't know if they've tried or they've got some concerns, but we'll see. We've shared our experience now, and maybe people will have some more comfort, and hopefully we've explained the technique well enough. And certainly anybody who has interest and wants to learn more, I'm happy to share slides of the technique and the steps, and happy to help people, get started doing this, because I don't want people to hurt themselves or patients, and I do think it's a good technique.
I mean, the cardiology literature, there is a registry there. So they're continuing to look at it. It's usually for balloon pumps or Impalas, that sort of thing. Sorry.
Yeah, we wrote, I was part of the consensus guidelines on percutaneous axillary access that was published by Sky. So it's in their journal. It's actually a pretty good review article, and it talks about other applications beyond complex EVAR. So that's worth a look to if you're interested.
Dr. Abai made the comment that it'd be nice to have a video online if you had a trainee or a colleague, a junior colleague who was looking. I'm sure, I know JVS CIT is interested in videos or video. There's probably a few places we could put it, but I know SMEDS would be interested in the video.
I'm pretty sure we have one. No, I thought I presented it at BAM, but no, it was another technique I presented. It's a good suggestion.
Okay. Any quick 2 or 3 takeaways for when you have to do operative bailouts or you get called for somebody else's CT's cuff or anything? Any quick 2 or 3 takeaways on lessons you've learned there? It's clear endo is your first line bailout, but on operatives, either acute or called to help with something later, any quick tips or tricks there as we finish up?
So I'll say that the location where we access in the second portion, it is actually fairly easy to compress. And in patients who've also had an A-line, you can see a radial A-line, you can see that you can completely dampen that A-line and compress the artery and get hemostasis. So don't panic. Correct pressure is always a good thing. For us, we like to do completion angiography, and we have the through wire, so we have the luxury of driving a sheath up. But even if you can't do that, or you don't have associated femoral access, you can exchange the larger sheath, as I think Dr. Gooding mentioned, for small like micropuncture catheter, and then cinch the perclose around that without locking it, puff that to confirm that you've got hemostasis. Now, if you need bailout, for me, you can always get a balloon in and get balloon control and then cut down if you wanted to cut down. We've used exclusively covered stents, self-expanding Viabon. I wouldn't use a balloon expandable stent in this location. And the patency's has been fine. We've had no issues with that, whatsoever. And since all these patients are in a prospective IDE study, we have regular CT follow-up, chest, abdomen, pelvis, that we can always see the axillary artery where we punctured. And so if there's a stent or we've accessed them, we always know that there's no issues with patency. We haven't seen late problems at all. So I prefer not to put in a covered stent, but I think it's a fine bailout to put a short self-expanding covered stent.
Awesome. Thank you.
I just received a note from Misty. She had to head to dinner. Sorry she missed the last bit, but I just wanted to thank our hosts. Terrific jobs from Buffalo and Texas. And Darren, thank you for being here. And for our invited discussants, much appreciated. And we hope to see you again next month. So have a good night, everyone.
Thank you.
Thank you.
All right. Ciao.